Hey, good morning. So we're going to start with chapter 15, postpartum adaptations. And I want to do our pre-lecture quizzes. I hope that you have already had the chance to read the chapter, take really good notes, review this material before you're watching the lecture, because we know the best way to use lecture is as a reinforcement of prior learning. We want you to really take advantage of the resources you have to study this material in advance of the review that we do in class. So we'll start with the pre-lecture quiz. We're going to do this Dora the Explorer style, okay? I'm going to read a true-false statement, and I want you to answer true or false out loud to your TV, your computer, your phone, however you're watching this. And then I will tell you the correct answer. So here's the first one. The postpartum period begins with the birth of the newborn. True or false? And the answer is false. The postpartum period actually begins with the birth or the delivery of the placenta, not the newborn. Okay, let's try number 2. Lochia typically begins as Lochia serosa. True or false? And this one is also false because we don't have serous or colorless or mucousy discharge. We have bright red discharge or bright red lochia, which is called lochia rubra following delivery. Okay, the next one, number 3. Cardiac output quickly returns to non-pregnant values after birth. And the answer to that one is false. It does take some time for our cardiac output to go back to our normal baseline. Number 4, the postpartum woman commonly exhibits bradycardia. True or false? And the answer here is true. We do see that the postpartum woman does often have a lower heart rate. Number 5, profuse diaphoresis is common during the early postpartum period. True or false? And that one is also true. We do see lots of sweating in the early postpartum period, also lots of shaking. A lot of the moms get really nervous because they've got the shakes, but that's totally expected. I'm going to save the fill in the blank questions until the end of this chapter PowerPoint. That way we can also test our working knowledge at the end of the review. So let's get started. Maternal psychological adaptation occurs in 3 phases. So these 3 phases are huge. This is very theoretical. This was developed by Ruby Revin, I believe, and I'm going to be so embarrassed if I've misquoted that, but this was a theory that said how women approach having a baby and adjusting to being a mom. So the first period is called the taking in phase. The taking in phase, where it's right after birth, the client needs other people to take care of her. She's obviously reliving that birth process. She's needing other people to support her as she just gets adjusted, takes it all in, what's going on. The next phase is the taking hold phase. This is where she's learning about her new routine. Either she's very dependent upon, family and support, or she could be very independent, be like, I've got this. I'm really getting the hang of it. The taking hold phase is definitely getting the hang of it, right? And then the third phase is the letting go phase. This is the phase in which the woman reestablishes her relationship with others. This is when it's probably good for her to start having visitors, getting back to speaking with people and having more socialization. So because women have to go through this entire psychological adaptation process of taking in, taking hold, and letting go, we really recommend that moms wait at least 24 hours for those visitors to come in. Of course, we're going to be up, it's the client's preference, and we're going to respect that as much as we can with our hospital policies, but really encouraging that bonding and the ability to process the taking in and taking hold phases before we're ready to let go. Okay, postpartum period. So this is that critical transition period for women, also for the baby. As we're changing a lot physiologically, that uterus is shrinking back down, the bleeding is starting to subside or at least decrease, and psychologically we're moving through these phases of transition and adaptation. This is often called puerperium, which is the period after delivery of the placenta. It can last up to 6 weeks, right? It's the 4th trimester, this postpartum period. Mom's life is totally rocked, right? Their whole world has changed. Everything that used to be my normal routine, my normal schedule is completely different during that first year after having a baby. And kind of got to learn where the mom has to learn where her identity is and where her original or normal schedule is going to work inside of the care of a super dependent newborn. And obviously family has to adjust to the new family member as well. So this fourth trimester is that recovery time up to 6 weeks postpartum. Okay, reproductive system adaptations. We talked a little bit about this. We talked about the involution of the uterus, and that is the contraction of those muscles, right, to help get our uterus back down to a normal size. Also, the epithelium or the lining of the uterus needs to regenerate, especially where that placenta has pulled off of the uterine wall. The lochia, we start usually rubra, we move into serosa, and then potentially alba. It's just the definition of the color. And we learned a little bit more about this in lab. So the consistency and the color of rubra, of lochia. And rubra is what we're really going to see in that initial postpartum period. The cervix, right? So the closure of the cervix is going to come back down. It was super dilated, 10 centimeters plus as we birthed this baby. And now it's going to start to shrink a little bit. And instead of having a nice, pretty little dimple in the middle, it's probably going to have a jagged slit-like opening. The vagina, right? The vagina has been stretched beyond its, sometimes beyond its capabilities as we've torn or we've had to have an episiotomy or we've had other issues. And the rugae that lines the vagina, so that rigid texture really has to grow back as we've stretched and dilated the vagina to be able to produce the baby, right? And then hopefully those walls will begin to thicken again and be capable of resuming sexual intercourse. We do want to wait some time. We recommend 6 to 8 weeks, at least until your follow-up appointment, so the OB can check everything out, make sure that you've healed nicely before we resume sexual intercourse. And then the perineum. So trauma from delivery could lead to pelvic floor dysfunction. So those muscles that sit between the vagina and the anus are really critical for coordinating things like urination, production of a bowel movement, and vaginal strength and development of vaginal muscles. So it's important that we teach our clients how to do Kegels, that we teach them how to take care of their perineum after delivery with like peri-care or peri bottles, witch hazel pads, sitz baths if necessary, and that we're monitoring them postpartum for issues with pelvic floor dysfunction like rectocele or incontinence. Okay, true or false? After birth, the cervix returns to its pre-vaginal delivery birth shape. And this is false. We talked about how it will have that jagged like slit opening instead of that cute little dimple that it had before. Okay, so let's talk about that cardiovascular system. So our heart and our circulatory system, what is happening? How are we adapting? So our blood volume and cardiac output increased dramatically while we were pregnant. So now we're starting to decrease. Of course, that decrease in blood volume is super fast. It should return to normal within 4 weeks. Because, we're losing that placenta that we have to perfuse, we're losing that baby that we have to perfuse, and the uterus is not quite as large. So the need for increased blood volume does not exist anymore. But that decrease in cardiac output is going to take a little bit to go down. The first 2 weeks postpartum, we definitely see that the client becomes bradycardic. Their heart rate is just a little bit lower than normal. Want to keep a close eye on the hematocrit level. That's the viscosity of the blood, right? How thick it is. And then, your hemoglobin as well, just to make sure our client hasn't become anemic through the blood loss. And then pulse rate and blood pressure. We talked about them being bradycardic for the first 2 weeks, but we could also develop tachycardia. And tachycardia would be more concerning in the postpartum mom because tachycardia tells me my client doesn't have enough blood volume. So their heart is compensating by pumping faster. Maybe I need to put on some volume expander like lactated ringers, potentially even albumin, or replace the blood, right? And then dehydration, just encourage them to take in oral fluids as quickly as possible. They're going to have to drink a lot more, especially since they will be lactating, and then also providing IV hydration as necessary in the immediate postpartum period. And then hemorrhage, right? Tachycardia tells me that there is a potential that I'm bleeding somewhere as my heart is compensating for the failure to perfuse. So be on the lookout. If your postpartum patient becomes tachycardic, that's very abnormal, but bradycardia is more of a normal abnormal in your postpartum patient. The BP. So the first 2 days, obviously our blood pressure is going to decrease as we are decreasing our blood volume. And also, we have maybe a tad of dehydration or hypovolemia from delivery. But about day 3 to 7 postpartum, we're starting to go back up our BP, and then we should be back to pre-pregnancy blood pressure levels by 6 weeks postpartum. So keep a close eye on that blood pressure. Now, when we say falls, we mean like a subtle fall. If the client's blood pressure is very low, again, I'm worried about hemorrhage. I'm worried about some type of bleed, like a retroperitoneal bleed, or accumulation of a blood clot in the intrauterine space, or even in the vaginal vault. So be on the lookout for low blood pressure and tachycardia. And by low blood pressure, I mean substantially low blood pressure, 90s over 50s, 80s over 40s. And then coagulation factors. So we do have an increased risk of blood clots for the first 2 to 3 weeks at postpartum. So sometimes they'll want to take a look at clotting factors like PT, PTT, INR, and platelet levels. So that's just something to think about. Remember, SCDs are super important. Getting up and ambulating is super important. TED hose might be necessary, especially if you have a C-section patient. Whatever we can do to really keep the blood pumping, vascular return to be really good. That way we don't have as high of a risk of developing a DVT or other blood clot. And then red blood cell production. So early in the postpartum period or the puerperium period, we do have decreased red blood cell production because we don't need as many red blood cells. We don't need as much volume. We don't need that extreme oxygen carrying capacity that we needed when we were perfusing another human and a placenta. So true or false? The drop in maternal blood volume after birth leads to a similar drop in hematocrit. And the answer is this is false. This is false. So we do see that blood volume drop, but the hematocrit typically remains relatively stable. It may even increase. And that's because of the loss of plasma. Plasma is the liquid portion of our blood. And remember, hematocrit is a measurement of the viscosity. Although we want to keep an eye on the hematocrit, that would be concerning if the hematocrit or hemoglobin started to drop. We expect it to remain relatively stable. So a low hematocrit would be an abnormal finding, indicative of hemorrhage. A relatively stable hematocrit is the expected finding, even though we have a decrease in blood volume. Okay, let's talk about that urinary system. So the urinary system, what is going on with these people? Well, they held on to a lot of fluids during pregnancy, so they're probably going to be getting a lot of this out, right? Although we're giving IV fluids, and oxytocin kind of makes us hold on to water. So the goal is to get a lot of this water out by increasing that GFR, increasing the flow through the kidneys, and we want to make sure that our client is urinating effectively. There are some things that can negatively affect the urinary system, like having a laceration, right? That might impair the sensation of having to use the restroom, or just generalized swelling, bruising, trauma to all of the tissues, especially those around the urinary meatus. And we know that we can even tear up to the urethra and even through the urethra, which can make a huge difference in the ability to know that we have to void and also to be continent between voids. Hematomas, these are, clots. These are accumulation of blood that might cause pressure on the bladder, the urethra, etc. And hematomas can also decrease voiding sensation potentially. And then if we've got regional anesthesia, like a epidural or a spinal, we might have decreased bladder tone. So we want to make sure that we are facilitating urination, however, is best for that patient given their particular circumstances of delivery. And then diminished sensation of the bladder might occur due to the swelling, numbing effects, etc. So not knowing that you have to use the restroom. That's why we often insert a Foley catheter in a client who's received a spinal or epidural, but not always. It depends on your hospital policy and how long you expect that client to labor. If the client is having difficulty voiding, we can always do a bladder scan to see if they have a large volume retained. And if we need to, we can provide a straight cath to drain the bladder. Remember, you only want to pull off about 1,000 milliliters at a time. Any more than that can cause extreme bladder spasms. So let's say the client has retained urine for a long period of time. You do a bladder scan, it shows 1,500 or 1,600 in the bladder. Don't pull it all off in one go. Pull no more than 1,000 milliliters off. That way we don't cause any bladder trauma. Okay, so causes of postpartum diuresis. So pulling fluids off postpartum. We talked about IV fluids that were given. Oxytocin has an antidiuretic effect. And as the oxytocin starts to decline in our system, we might see increase in urination. Buildup and retention of extra fluids during pregnancy. All of that water weight is going to come off. And then decreased production of aldosterone. Remember, that's an adrenal hormone that helps us hold on to sodium, hold on to water. And so as we decrease production of aldosterone, we are going to get rid of sodium and get rid of water through our urine. Okay, let's talk a little bit about the musculoskeletal and GI system. So with our joints, we talked about relaxin. Relaxin is that hormone that allows those joints to move and kind of shift to allow for delivery, right? And this is why we have a lot of women that are pregnant have trouble with sciatica or joint pain, even around ligament pain due to that hormone relaxin. Hopefully, the goal is that all of our joints return to that pre-pregnancy state, except for our feet. Sometimes the feet stay kind of, our feet grow in pregnancy, and sometimes they stay kind of about a half size larger after delivery, which is very interesting. Women commonly experience fatigue and activity intolerance for weeks after giving birth. This is a huge endeavor. It's called labor for a reason. And our bodies need quite some time to adjust to all of these physiologic changes. And then abdominal muscle tone is diminished after birth. It makes sense. We have this hugely distended abdomen. We stretched all of the muscles, all of the skin tissue, and now we need to do exercises to really come back to normal with our abdominal muscles. One thing that we sometimes see is a condition called diastasis recti or rectus diastasis, depending on, if it's an issue with one or multiple of the muscles. But this is a separation of the abdominal muscles that allows a protrusion through the middle. And there is only one way to fix this. Unfortunately, this does require surgery. These muscles are shorn to the point that they will not reattach on their own. The goal is that muscles grow back together totally normally. But if you have a postpartum patient, it's been several months since delivery, and they're still having trouble with the abdominal muscle tone, there's a soft mass palpated between the muscles, we might have a condition called diastasis recti. And then gastrointestinal system. So the GI system quickly returns to normal. Lots of pressure is relieved off the organs. Hopefully we're able to produce a bowel movement, although we do have decreased peristalsis and decreased bowel sounds for several days. Especially if we've received any type of opioid postpartum. Constipation is super likely. And then also with the bottom being very painful, maybe having lacerations or an episiotomy or burning, any kind of pain down there might keep us from really wanting to strain to produce a bowel movement, which can cause constipation as well. And then because clients are kept NPO before they deliver, they're typically really hungry and thirsty right after delivery. Okay, so integumentary, our skin system, our respiratory system, and our hormones, our endocrine system adaptations. So all of that hyperpigmentation we saw during pregnancy, like our melasma of the face, our linea nigra of the belly, hyperpigmentation of the vulva and the areolas, all of that is going to start to fade out. It does take some time, especially for breastfeeding. Typically, you see hyperpigmentation from the stimulation of the nipples. However, we do see that the pigmentation other places starts to fade back to your normal baseline pigmentation of the skin. Stretch marks, which might be bright red or even dark purple, are going to fade to silvery lines in most cases. And then diaphoresis, we already talked about, super common for about a week postpartum. Lots and lots of sweating with our integumentary system. Okay, and then respiratory endocrine system. So with our respiratory system, we have, we look at these levels, our tidal volumes, our minute volume, our vital capacity, all of these are going to increase, right? Our functional residual capacity. Why? Because we don't have a baby pressing on our lungs and our diaphragm. So we should have normal lung capacity about 1 to 3 weeks postpartum, once our lungs are able to expand and really take in the air that they were prior to pregnancy. And with our endocrine system, we see those estrogen, progesterone levels drop very quickly. Our placental hormones decline rapidly because we no longer have that placenta. And then those prolactin levels decline within 2 weeks if the client is not breastfeeding. If the client is breastfeeding, they'll continue to produce both prolactin and oxytocin to support successful lactation. Okay, speaking of lactation, okay, the newborn is going to be stimulating the breasts to help them produce milk. The breasts should start to secrete milk about 4 to 5 days after having a baby is when the full milk comes in. Prior to that, we have colostrum, that rich goldy goodness, right? That's got lots of antibodies and lots of immune support for baby. And the secretion of the milk is a result of an interaction between multiple hormones that are working in the body. Progesterone and estrogen, which supported the pregnancy and are now decreasing. Prolactin, which encourages lactation and the letdown of milk. And oxytocin, which stimulates the breast to also during that letdown phase, but also helps to contract our uterus, right? So that's a good thing. When we're lactating, we're stimulating oxytocin, and that oxytocin is actually doubling up, helping us not just with lactation, but with also reducing our uterine size so that it is back to eventually back to pre-pregnancy size. So engorgement. So this is the process of those breasts swelling considerably, huge increase in blood supply, huge increase in lymph supply. We see this engorgement happen just prior to that milk coming in. Frequent emptying of the breast is really going to help with this if you are breastfeeding. Warm showers and compresses before feeding really help get things flowing and prevent mastitis, which is like inflammation or infection of the breasts caused by clogged milk ducts. And then if you are breastfeeding, sometimes it's nice to put cold compresses in there between feedings. Although we know that cold compresses can decrease milk production, it helps with the leaking and the really uncomfortable engorgement that can occur. If the client is not breastfeeding, we really want them to keep ice packs on their breasts with a tight supportive bra. We're going to avoid all breast stimulation. So no hot showers with water running over the nipples, no stimulation of the breasts from the baby or anyone else for that matter. And just really trying to keep those breasts unbothered, cold, and restricted. So for the woman who is not breastfeeding her uterus, can't even talk, her newborn, for the woman who's not breastfeeding her newborn, which measure would be the most appropriate to relieve engorgement? So she's not breastfeeding. What could she do to get the engorgement to go down? Warm showers? Not that. That's going to increase milk production. That's going to cause that engorgement to continue. Nipple stimulation? Not that. That's going to also help us to produce milk. Ice to the breast. This is it. And oftentimes you hear people say manually expressing some milk off. That'll help. It just gives me a little bit of relief. Although it may provide temporary relief, it is going to be stimulating your breast to continue producing milk. So it's going to compound the issue instead of making it better. We definitely want ice to the breast and a tight fitting, really great supportive bra. Okay. The ice should be applied to the breast 15 to 20 minutes every hour. And it talks about the reasons why the other answers are not correct. So let's talk about ovulation. So going back to producing ova that can be potentially more babies, right? And the return of our menstruation or our period. So there's this huge interplay of hormones as they start to regulate out. Estrogen, progesterone, prolactin, oxytocin. Non-lactating women usually start their period 7 to 9 weeks after birth, but lactating women may see that their period or their menstrual cycle doesn't come back up to 18 months after delivery. It's really going to depend on how often they're breastfeeding and for how long they're breastfeeding. Remember, breastfeeding is not a cure-all for not getting pregnant, though. We definitely should be using some type of reliable protection if we're not wanting to get pregnant during that postpartum breastfeeding period. Okay, psychological adaptation. So we talked about the initial stages directly after delivery of taking in, taking hold, and letting go. This is going to be further on in our postpartum psychological adaptation. that attachment, right? That bond between the parent and the newborn. Skin to skin is really going to help with this attachment adaptation. Being able to provide care for the baby, naming the baby, being really involved in all of the day-to-day activities and care is going to be super helpful for promoting attachment, and not just with mom, but also with dad. Involving dad in the care of the baby is going to help produce attachment, psychological adaptation, paternally as well as maternally. Early and sustained contact between the newborns and the parents is vital. We want them to be with baby as soon as possible and for as long as possible. Factors influencing attachment may include the environmental circumstances, things like, do we have things like COVID, right? We weren't able to put babies in with moms, or the environment's not safe. Maybe mom had come in and she had been using some type of illicit substance. We have to make sure that the environment is safe before we can promote attachment and mom-baby contact, right? And then obviously newborn health and quality of the nursing care. So is the baby healthy? Is mommy healthy? Because if that's not the case, then maybe working to facilitate attachment right away is not our number one priority. We got to keep mom and baby healthy first and foremost. Okay, 4 stages of becoming a mother. Okay, so these 4 stages of becoming a mother, or BAM, becoming a mother, is commitment, attachment to the newborn baby, or excuse me, unborn baby, preparation for delivery, and motherhood during pregnancy. So we want acquaintance and attachment to the infant after the baby is born. We want them to really learn how to care for the baby. And then that physical restoration has to happen too, right? Not just the psychological commitment to the baby and attachment to the baby, but also the ability for our bodies to go back to normal and moving towards our new normal, because what was our normal schedule, what was our normal routine and identity before is a lot different. And we have a new normal or new baseline. And adjusting to that is going to be a process. And then lastly, achievement of your maternal identity through redefining self to incorporate motherhood. It really takes about 4 months for these moms to really step into that role as a new mama and feel comfortable as a mom, right, with their new identity. Okay, variables that can affect that maternal role attainment are the ability to feel like a mom. First of all, confidence. If you don't feel like you're capable of caring for the baby, or you don't feel like, it's the right time for you to be a mom, you have decreased confidence, that can certainly affect this. Age, we do see that younger moms really struggle sometimes with maternal role attainment, especially if they're a minor, because they're still struggling with their role with their mom, right? And as grandmas try to step in and help, sometimes we see maternal confidence of our minor mothers decrease because of those strange relationships that are readjusting within their home. Relationship with the father can definitely affect the ability to attain that maternal role and comfort with that maternal role. The birth experience, if it was extremely traumatic, we do see some psychological avoidance sometimes of baby hurt me, this was horrible, I have trauma, I have emotional dysregulation because of this experience, I'm not ready to deal with this baby right now. Stress, having a great support system can certainly promote maternal role attainment, but then having a not so great support system, whether that be an under-supportive or over-supportive system, can really affect our ability to grow in that maternal role. Personality traits, some people just aren't super affectionate or warm. And it's kind of hard as an OB nurse to see moms that aren't super attached to baby right off the bat. But sometimes that's just their personality. And it really is going to take them a while to work into that maternal role. And their maternal role may look different than what my expected maternal role is. Child rearing attitudes, people have different attitudes about how to raise kids and the relationship that you should have with children. Self-concept, our understanding of ourself, our identity, role strain, right? I'm a mom, I'm a worker, I'm a wife, I'm a coach, like all these different roles that you have, trying to juggle those may really affect the ability to attain that ideal maternal role or anticipated maternal role, right? Health status, if you're sick, it's going to be difficult to work on the psychological and psychosocial aspects of adjustment. Preparation during pregnancy, not having a lot of time to prepare for this change in your role might cause issues. So if you know for a long time that you're going to be a mom, it gives you more time to adjust and adapt. But if you find out that you're pregnant the day that you deliver, it's going to take quite a bit of retrospective adjustment and ability to work through a lot of those psychosocial and psychological aspects before we're able to work on attaining that maternal role. A relationship with your mom, we talked about a little bit already. And then, of course, existing depression or anxiety. And then those are the maternal variables. Let's talk about the infant variables. So if baby has an appearance that is concerning to mom, let's say the baby doesn't look like mom, or baby doesn't look like dad, or we see this a lot with our women of color. When they have a baby, their babies typically lack a lot of pigmentation, and they develop that pigmentation over the course of a couple days or a few weeks. And sometimes they're really like taken aback at how light tone their baby's skin is. And so sometimes that can take some adjustment into feeling like I am this baby's mom because baby doesn't look like you, or maybe baby doesn't look like dad. So that takes some adjustment. Also, if baby has some type of congenital issue or a birth defect, right? Cleft palates, hydrocephaly, anything that would cause some type of appearance change, it sometimes can take a little bit to bond with that baby and for that mom to really adjust to her role as mom and establish that attachment if there's some type of appearance abnormality. And then if the baby is super responsive, or if the baby is unresponsive because they're on, they're receiving care, or they've had some type of birth injury, or perhaps they have some type of existing cognitive issue or developmental issue, they might not be as responsive, and therefore it might be difficult for mom to really feel connected to baby or attain that maternal role that she is aspiring to. Temperament, you got cry babies, and you've got really good babies. Having a difficult baby or a colicky baby can really affect the ability to feel comfortable in your maternal role and confident in your capabilities of providing for the baby. And of course, health status, which we talked about. Then we've got baby blues. So baby blues is actually pretty normal. It is expected to have some mild depressive symptoms, a little bit of anxiety, some mood swings, tearfulness, increased sensitivity, being really tired. Usually peaks about days 4 or 5, totally gone by day 10. And we get good sleep, good rest, we get into the flow, and things get better, right? That's kind of normal to expect that. But when those symptoms last longer, or they're more intense, crying for no reason, feelings of hurting yourself or baby, inability to bond, inability to complete daily function activities, right? Anything like that, very, very serious. We might have a huge risk of postpartum depression or postpartum psychosis. We need to report this to the doctor immediately. And our dads or our partners are going to be our best resource for identifying this is not normal for my partner, and we need to get this looked at. Also, postpartum depression and psychosis can cause poor bonding, alienation from our loved ones, dysfunction with our ability to complete ADLs, and even violent thoughts and actions. So it's super important that we intervene early and aggressively in these situations to prevent injury to anyone. Okay, here's the Edinburgh Postnatal Depression Scale. This depression scale is often used within the first 24 hours after delivery, but then we use it again at the doctor's office at our first follow-up appointment. And this is really going to help us get a baseline of how we're feeling, and then we're going to reevaluate to see if we're still feeling okay. These questions are on kind of like a Likert scale, not at all, not very often, yes sometimes, yes most of the time, and they're going to help us identify any type of behaviors, thoughts, attitudes that may be concerning for postpartum depression or postpartum psychosis. Okay, and our partner psychological adaptation. So we talked about how mom has to take hold, let go, and then also go through that becoming a mother stages of adjustment. Our partner also has a 3-stage role development process. Their expectations. Typically, dads are super excited, or partners are super excited to see baby. Because I'm going to be a dad. But then the reality of, oh my goodness, I have this baby to care for. Oh, this baby is great. It's wonderful. It's exciting. To, oh, I have to do all of this care, right? And I have to be there to provide support. And I'm tired too. And I'm also trying to balance my roles. So there's that reality hits as well. And then transition to mastery, really feeling good in their role as the other parent or as the partner of the mom, and having that increased self-esteem and that strong attachment to the newborn. That was just first excitement and then attraction, but now is that really deep attachment and commitment. And then cultural considerations are something we always have to consider. Cultures vary in their postpartum beliefs. What is okay and not okay after having a baby? What kind of customs and practices do they participate in? We must be always open, respectful, non-biased, non-judgmental, and willing to learn about our ethnically diverse population's cultural practices and belief systems. That way we can support them. Understanding various cultures' view of the postnatal period is super important because for them to be well, we have to consider all aspects of their being. So not just physical, but also psychological, emotional, and spiritual domains of their health is going to be important to support during recovery. Okay, so that is chapter 15. Let's do 5 quick fill in the blank review questions before I end this PowerPoint and move on into chapter 16. Okay. The uterus returns to its normal size through a process called what? What is the process where the uterus is returning to its normal size? Involution. Involution is the correct answer. Number 2, lochia blank occurs from postpartum days 10 to 14. So remember we talked about the color and consistency and timing. I don't think we dug too much into the timing because we did that mostly in lab. But which one is going to happen between postpartum days 10 and 14? And that's going to be alba. Lochia alba. That's that whitish yellow. So rubra is that dark red, lasts up to 4 days. Serosa is the pinky brown, which is older blood, right? 4 to 10 days. And then alba is really going to be 10 to 14 or beyond, that whitish yellow. Okay. Number 3. What is the name for the uterine contractions that occur after birth? And I kind of gave you a hint with the word after. These are after pains, after pains. And we increase after pains when we nurse, stimulate the nipples, give oxytocin, complete fundal assessments in order for that uterus to contract down and get back to normal size. It might be a little bit painful with those after pains. Okay, number 4. What is the word that means the swelling of the breast tissue that occurs 2 to 4 days after birth? Swelling of the breast tissue occurring 2 to 4 days after birth. That is engorgement, engorgement. And remember, we handle engorgement differently based on if we plan to breastfeed or we don't plan to breastfeed. And number 5, fathers or partners go through 3 stages in their road development process. What are those 3 stages? Well, stage 1 is expectations. Stage 2 is reality. And stage 3 is the transition to mastery. Thank you so much for reviewing chapter 15 with me. I'm going to end this PowerPoint and start on chapter 16.